Okay. Let's talk about money in terms of copays, because you alluded to that.
Sure.
Do some of these drugs have different copays as a group than others?
They may. Clearly, within each of these classes we've talked about, most plans are going to have a preferred or two choices within each category. So there are going to be lower cost options available in the DPP-4s, SGLT2s, GLP-1s, but not all are available, as we talked about earlier. So you're going to have to, as a physician, you have to work with the plan or the formulary design of the patient to try to figure out what the choices are that are going to be in the lower tiers and the lower cost. One comment about the sulfonylureas, they're old drugs, they're all available generically, and they're very inexpensive. So if a patient is really money sensitive, you may have some primary care docs who are going to offer that as an alternative, which is not ideal, as Helena suggested. But because they're inexpensive, we still see a fair amount of use of sulfonylureas, and the plans certainly aren't promoting that. There's no plan that's saying use a sulfonylurea first, typically.
We
They're
are
saying
in the
metformin.
21st century,
Yeah.
right? Those are old drugs. Not all old drugs are bad, but we have new drugs that are good.
Right.
From what I heard over here. That's surprising, I guess, and a bit depressing.
Well, it is, but a lot of your Medicare patients are very cost sensitive, so they're looking for generics. So if you look at the generic rates of use in that population, it's 90% of the drug use is approaching 90% is generic, because the copays are very, some cases it's zero copay, right? If a drug falls on the first tier of a typical Medicare Part D benefit, there's no copay. If it falls on the second tier as a generic, it may be a $10 copay. So it's very aggressive for these patients to try to get that low-cost drug if they can get it.
Other than money, are there some of these drugs which have better patient adherence than others? Does patients like them better?
Well, I think, the adherence is not a major issue with the SGLT2 inhibitor. It's one pill a day, so it's not a big deal. And as we discussed, GLP-1 inhibitors, when you want to use them, it's not only one injection a day as it used to be, or two injections a day. Now it's once a week. So the compliance is better. And patients don't mind taking an injection once every week rather than once a day. So it's easier.
So what about long-term safety data? We know about the good side. Are these drugs dangerous in any way? Are there side effects we need to know about? One drug class versus another that you'd rather prescribe?
Well, in terms of safety, the cardiovascular outcome trials have already shown that they are safe with a few limitations.
Like what?
So the limitations are like the class of SGLT2 inhibitors. They can drop the blood pressure. They can also be associated with increased incidence of vaginal and genital infections, mycotic infections, not necessarily urinary tract infections. But so those are potential side effects, but relatively minor. They can be easily mitigated and avoided. The GLP-1 receptor agonists, typically it's the GI problems, nausea, vomiting, diarrhea, which are also mitigated by gradual escalation of the dose. So there are lots of things we can do in terms of minimizing the potential side effects. But all in all, they are safe drugs.
Yeah, the only thing I would add to that is that there has been this concern about acute pancreatitis with incretin agents, both with the DPP-4 agents and the GLP-1 receptor analogs. FDA is still waiting for more data. We still don't have a final answer on that. But if a patient has history of acute pancreatitis, probably wise not to use these agents. Similarly with SGLT2 inhibitors, Helena mentioned the mycotic infection. That's the main concern, more in women than in men, but still the incidence is less than 10%.
But 10% is not zero.
Yeah,
so
that's exactly right.
And then there is another concern, and that is it actually was amputations with one of the drugs of the class of the SGLT2 inhibitors, canagliflozin specifically, lower limb amputations. But that has not been seen in the study that was just published, the Credence study, so they did not find that. So the drug has that warning in itself. And another one, orthogliflozin, another drug of the SGLT2 inhibitors, also has that on their label. But this study, Credence, did not find any increased incidence of amputations.
Tricky, because a number of diabetics are going to get amputations no matter what. So you've got to,
that's the point.
Yeah,
that's
parse
exactly
all of that
the
out.
Point. Yeah.
What about injectable versus oral? I'm going to ask the obvious question, what do patients like?
Well,
Surprise me here.
I'll surprise you. They love injections, just kidding. No,
Yeah.
they actually would rather pop a pill than take an injection. But what I do with injectables is exactly what I do with insulin that I alluded to at the beginning of our conversation today. I just give them the first shot in the office, and then the fear factor is over. So they don't have to worry about it anymore. It's not painful. And it is simple, and especially if it's a once a week, as said, it's a once a week preparation. It's a no-brainer. It's very simple.
But are there cost impacts of injectables that the orals don't have?
Well, I think the question of oral versus injectable does come back to cost from the plan perspective. So you might have a situation where the injectable is less expensive than the oral. And a plan might say, we want you to use the injectable before you can use the oral. Now, we're going to have potentially an oral GLP-1 that's coming to market. We don't know where the price is going to be. If it was priced at a premium to the injection, I suspect that plans would require the injection first, because there's no reason not to say you can take a once-a-week injection. These devices are great. The pens are very easy to use. The needles are small. It makes it very easy. So it's not always the most convenient or easiest dose that the plans are in favor of, because cost can play a big role.
But I can hear the patient saying right now, got injectable, got a pill, I'm taking the pill. Nope.
You might have to take both.
Or both.
Actually,
That's
there is a reason to
Yeah.
use them both together, because
Well,
they
it-
complement each other's
That's
action.
right.
And adherence is a funny thing. There's a lot of issues related to adherence is cost-driven, right? The patient can't afford it, so they're non-adherent. But there's lots of other reasons to be non-adherent. And there's no guarantee that somebody that gets a once-a-week injection is going to be any more adherent than somebody who has a once-a-day pill.
Except
because they still
that-
have to remember every week to take the injection.
Unless you bring them back to your office once a week.
Correct.
And then you actually have a real hard follow.
But then the health plan
It's
doesn't
not
want to pay for the
feasible.
office
They won't pay for
visit.
the office visit. When you compare primary care physicians versus endocrinologists, do they tend to choose one agent more than another?
Yeah, typically, as Jim said, they tend to use more sulfonylureas. They seem to like sulfonylureas because they're inexpensive. There are no calls for pre-authorization. It's just easy.
But
However,
it's also inertia.
it's the inertia.
Right.
It is the inertia. But they don't want to handle all of in general, all of the strings attached to the newer drugs.
If you had a
primarily the
message
cost
for
of
them,
it.
what would it be?
My message would be, please think about your patients first. I know it's inconvenient. I do pre-authorizations. I don't like them. But if I'm worried about my patient, I don't want them to have hypoglycemia. I don't want them to be gaining weight in general.
Yeah, I think these drugs are not going to go away, because they can be useful in certain people who are not financially well off, can't afford to pay the copay. And look at it globally, where these drugs are either not available or they're very, very expensive because people have no insurance. We are fortunate in this country that majority of the people have some kind of coverage. So it comes down to only a small copay, or copay can be higher until these drugs go generic.
Okay, let's just put the 900-pound elephant on the table. What tier do these new drugs fall into?
Well, I think the newer drugs at launch typically are in a non-covered position. Right. And then the formulary committee has to take a look at it, figure out where it's going to be placed, do a full analysis of the science, and we look at all the same things that physicians look at. Efficacy, safety, tolerability are paramount first. If it passes those as being favorable, then we look at cost, and then we compare it to what's already on formulary or what's already in the basket. And I think what you see is a mixed bag. Most of the time you're going to see a preferred agent or two in each of these categories on a preferred tier. And the numbering doesn't make sense. People say, I want to be tier 3, I want to be tier 2. The numbers are all over the place. The bottom line is you're looking to have drugs in a preferred branded tier from each of the classes, DPP-4, SGLT2, GLP-1s. But others are going to either be not covered at all because the plans are trying to drive to the preferred products on the formulary, or they're going to be in a higher tier. Now, with copay assistance programming, you can certainly work around that, but you might have to fail one or two preferred drugs within one of those therapeutic classes first before you can get one of the non-preferreds.
And where does Medicare, Medicaid reimbursement fall in all of this?
Well, Medicare and Medicaid is similar. I think the Medicaid plans are also driven by formulary process. They're driven by price. They're driven by mandatory rebates that are paid on the Medicaid products, drive a lot of that choice. And Medicare, similarly. There's contracting in the Medicare space. There's also a limit as to how many drugs a plan wants to put on a formulary. Plans also worry about adverse selection, right? If you think about that. If your formula has every drug imaginable on it, you're going to get all the diabetics are going to join your plan. So you have to have some available, and they're also evaluated by the local carrier units for Medicare. They look at them and say, yeah, your formulary has enough choices, so we're going to accept that. We also have that for the state health exchanges. Those formularies have required numbers of drugs within the categories. So at a minimum, you might need 10 drugs in the diabetes category on formulary. Doesn't necessarily 10 from each category, but 10 across all the categories. So it's a bit of a juggling act to try to build the formularies, and that's why some of them are very different.